Hi, my name is Liz Kearney, the Health and Social Work Manager of the North East Sector in North Lanarkshire Partnership. This piece of work we are going to share with you today fell from the Living and Dying Well Collaborative. 3 GP practices in Coatbridge agreed to test out our frailty multidisciplinary team model. It is in line with the evidence base, patient and carer involvement, the GMS contract, the integration agenda, and the strategic commissioning plan for the North Lanarkshire Partnership. Achieving excellence directs the way forward, and this piece of work will enhance our ability to drive this forward around realistic medicine, personalised care, the vision of bringing general practice and communities services all closer together, population-wide prevention, self-care, care support and planning, and most definitely influences the health inequalities agenda. The model we feature today has evolved over time based on the learning from multiple tests of change prior to the COVID-19 outbreak. We have utilised this time during the COVID-19 outbreak to focus our work around ACP development and training in line with the direction of travel from the Scottish Government, and have developed strong links with the third sector in doing so. We are currently in talks with a number of GP practices across North Lanarkshire to expand and develop this concept across all of the North Partnership.
Hello, my name is Liana McMillan. I'm a GP in Atrium practice in Coatbridge. I've been working with Dr. Talbot trying to develop an MDT approach to looking after patients with frailty. The results so far are very positive for us involved in the team, but more importantly, obviously, for all the patients. And we really hope to be able to progress this work and importantly spread it further than the 3 practices currently involved. I thought I would start by taking things right back to the start to ask, why are we even talking about frailty? Where did it come from? When I was training and working, frailty wasn't a thing. We spoke about people being frail, but we didn't speak about people having frailty. Clearly affecting old people, it can coexist with lots of other morbidities, but it is important that it's looked at and considered separately. We know that our older people living with frailty are at very high risk of adverse outcomes, both to their physical health, their mental health, their independence. And that can happen as a result of something that to the rest of us looks like it's been fairly minor insult to them. And I think it is important to remember that frailty is not an inevitability of old age. It is an illness, and it can be improved. But first of all, we have to find these people. So the way that we have been doing that is by using a tool called the Electronic Frailty Index, the EFI, run through Spire. Now, that is a risk stratification tool. It is not a diagnostic tool, and looks at about 36 different markers of aspects of health, not just medical conditions, but things like vision, dietary changes, weight loss, mobility, home care facility, whether people are housebound, all these sorts of things are used to search for people. Spire will stratify those people into mild, moderate or severe frailty, but specific to Spire, it also looks at people who are moving within those categories, and that's where we think the biggest importance of the work lies. And so we have been looking at people in the escalating to moderate category. And in our team, we had myself as a GP, we had a consultant, we had dietitians, district nurses, rehab team, mental health representation, and the plan was to get some more people depending on the needs that we identified, and we ran those meetings monthly. I took responsibility for searching through the Spire data, discussing with the other doctors if there was anyone they identified from the list that they would wish us to discuss. We identified a key worker. Now that should ideally be somebody who knows the patient. As we found out as the work progressed, sometimes we didn't know who these people were, which is really useful to find out. They would go and do a real, usually quite lengthy chats with the patient, trying to establish all basic information about medical history, current issues, drug history, compliance, any worries the patients had, but also things like their home care facilities, their family support, whether they had any financial concerns, energy concerns, lots of wide-ranging information. And then progressing on to anticipatory care planning conversations, including resuscitation if appropriate at the time. That information was brought back to the meeting, discussed at length with all members of the team. The information was recorded in the patient's notes, any relevant information transferred onto the key information summary, and any actions carried out instantly without the need to fill in referral forms or anything else. Very, very positive results from all involved. Clearly, our aim is always to do the best for our patients, to provide the best quality care that we can, and I believe this really, that is the most important thing about this whole project. That's exactly what it does. We know that an MDT approach is used in lots of other specialties to great effect. It's the gold standard for how we provide care, and we have a real opportunity here to develop a really specific service for our people with frailty. It's a proactive approach, which is what we do in primary care. It's not reactive when we maybe all feel it's a bit too late. And everybody involved in my team, very, very positive early adopters of this, and I really hope that we can engage other people and spread this work. This is a pre-recorded chat today, but I'm more than happy to be contacted if anybody has any questions or queries about anything that we speak about.
At a multidisciplinary team meeting, an anticipatory care plan has been done. You have social work there, you have carers there, you have the continence, the district nurses there, sorry, you have Equals Advocacy there. All these people that say, I'll do that, I'll do that, I'll do that, and you think, this is great, we don't have to do it. Initially, the health visitors did first to set the initial assessment, but because of COVID and redeployment, they weren't able to do that. So we've started to work with Equals Advocacy, and that, I would say that's been very successful. They have been great. I've learned an awful lot from them. I don't think we necessarily have the skill set or the time to do what the third sector can do, because, and we don't have the knowledge base. So that's what I've learned from working with Equals Advocacy and all these other agencies that are out there. We might not, we'll do a referral to social work, but there is so much more out there than social work. And it's about learning how these other people work and how to contact these other people. So we would do the referral. We might then get a phone call back from the patient to say, it might be 3 weeks saying there hasn't been any contact. They don't have. So we've then got to chase that up. Whereas with this, we don't need to chase that up. It is all there at the multidisciplinary team meeting, and it's all organised. It doesn't come back to the practice because it's really, really time consuming for a practice, all this, because we are, from a patient and the patient's family perspective, we seem to, or they seem to think that we are their only point of contact. Families have been delighted because these people think that they're alone. They've been doing all this on their own. They're not aware of what actually is out there. And they're not alone. And we've had a really, really good feedback from the patients, not particularly the patients, to be fair, their carers. I had no idea of the impact that was on people that are working full time, that are trying to look after their elderly parents, and most of them have dementia, or they've got Alzheimer's, or they're falling, and these people are doing all this on their own. And they quite often would say to you, I don't need anything, I'm okay. But they'll agree to the anticipatory care plan, and what comes back is they need all these agencies involved with them. And then they phone you back and they say, that was great, thank you so much. And that has been really, really good, because it makes you feel as if you've achieved something. I would say the biggest problem has been the IT and the systems not speaking to one another. So primary care doesn't speak to secondary care, that doesn't speak to the community, that doesn't speak to statistics in Scotland for data capture. From our perspective, it's working okay, but we're obviously very keen on the practice next door, maybe do it in a different way, so you can pick up ideas from other people, which I think, and that's what's good about the multidisciplinary team. But I think it's worthwhile. I like it. I think the practice likes it. I think if we streamline it a bit, yes, it will work well. I think from the patient's perspective, it's excellent. It's excellent.
Hello, my name's Brenda, Vincent. I'm the Service Manager of Equals Advocacy. Part of our role is to help older adults to plan for their future care needs. We assist them to complete anticipatory care plans. We've been working very closely with the team. The GP practice identifies people using the e-frailty tool, and Advocacy holds that first initial conversation.
I was wondering, could you tell me, Agnes, why did you want to do an anticipatory care plan?
Well, as you know, I have a diagnosis of dementia now for 14 years, and about 4 or 5 years ago, I started to experience severe respiratory challenges, which resulted in me getting paramedics to my house and emergency admissions to hospital. And this is not good for people who live with dementia. And it's much better when it's not a family member, I feel. And when Donna read it through, or I read it over the phone to her, she was amazed how we got all the relevant points in the way we done it, because there's not a lot of space.
You were very clear in your anticipatory care plan, Mrs. Houston, that reducing hospital admissions was something that you absolutely wanted to happen, but also if a hospital admission was necessary and unavoidable, then you wanted to be treated very quickly and returned home for further care and support. I know also that when you were doing your anticipatory care plan, you highlighted who was important to you and who was important in your life.
There's a relief, not just to me, you know, which is fantastic, but my daughter, you know, she's in England, so she feels relief that whether she's there or not, and while she's to come to me, that this is there. So it is written down.
So after watching the film, I hope you can see why it was so important for Agnes to complete her ECP. So what can we learn from this test of change that we've been involved in? We've had to adapt and change our work around COVID. This has been a challenge, but hasn't stopped us proceeding with this test of change. Probably one of the biggest successes that we've had is we've extended the advocacy role to include frailty assessments. The information provided is richer and helps the team and the MDT to focus not only on the ACP, but other necessary inputs. Here is a snapshot of the process for one individual. Following the anticipatory care plan and frailty assessment, Lisa brought back to the MDT some of the findings. After a lot of discussion, it was decided that there would be an increase in home support. OT assessment was arranged. A home safety visit by the fire brigade to put in place fire retardant bedding. Continence assessment was required. It was highlighted that the falls team need to become involved because there was a risk of falls, and an emergency carer support plan was put into place. So what still needs to be done? We need to reach out to more older people using this approach. We need to consider if these frailty assessments could be undertaken by all advocacy workers in the community, because they provide so much intelligence and feedback to GP surgeries. We need to use the evidence, feedback and information to improve the process, and most importantly, to continue to monitor and evaluate the differences made to the older person's journey. What matters to me, it's really important that we actually use the person-centred approach. Stop me getting into hospital. If I go into hospital, make it timely and safe. Don't let me get stuck, and let me die with dignity.